My name is Jim Ellison. I'm an Associate Professor of Psychiatry at Harvard Medical School, and I'm the Director of Geriatric Psychiatry at McLean Hospital in Belmont, Massachusetts. I'm going to be talking about geriatric depression or late life depression, which is a very important clinical condition because it affects 2 to 4% of elders, and it's a debilitating condition, and yet it's a very treatable one. One of the most important points I like to make is that late life depression is not a normal part of aging. Late life depression is very responsive to treatment, and in fact, as responsive to antidepressants and psychotherapy as depression in younger adults too. So it's very important to recognize, identify, and vigorously treat mood disorders in older patients. I like to talk about late life depression because it presents somewhat differently from depression in younger adults. For example, we see some older adults who present with what's been called a depression without sadness. The sad mood and the depressed mood are much less prominent than changes in activity such as apathy, social withdrawal. We can also see changes in cognitive functioning like slowing and executive dysfunction. Sometimes that's associated with changes on the MRI that show small vessel white matter disease. A term, vascular depression, has been coined to describe this kind of a depression. In addition, we sometimes see older adults who present with concerns about the functioning of their body. This somatization is a characteristic of older adults. And we see, for example, patients who are very concerned about their bowel function or have excess pain associated with neuropathy or diabetes or with arthritis that's much worse because of the depression than it would be without the depression being active. We also see older adults with psychotic depression. This is more common in the older patient than in the younger patient for delusions to be a part of the depressive syndrome. And it requires special considerations, often the use of antipsychotics, and more often than non-psychotic depression, the use of ECT. Sometimes the somatization also focuses on cognitive functioning, and we see patients who are very concerned that they have a dementia. The patient who presents to a memory clinic complaining that they have dementia may be especially unlikely to have dementia because so many people with cognitive impairment actually are unaware that they have a cognitive impairment. But when individuals present very distressed that they're losing their cognitive abilities, one of the things that might represent is the presence of a depression with a focus on cognitive difficulties. This used to be called pseudodementia. Now we're more likely to call it the dementia syndrome of depression, and we think that's a more accurate term for the condition because what the dementia symptoms of depression may represent are concomitant brain dysfunction associated with depression, or perhaps the unmasking of a neurodegenerative disorder that will become more prominent later. We also may be concerned that depression left untreated could increase the likelihood for dementia, and this could occur by a number of different routes. For example, simply the depressed patient doesn't take as good care of themselves. But also, depression produces metabolic changes such as inflammatory systemic changes, activation of the sympathetic nervous system, increase of circulating pro-inflammatory cytokines, and all of these are associated with a greater likelihood of developing dementia. Now, the treatment of depression in later life bears a lot of similarity to treating depression in younger adults. The antidepressants that are useful for younger adults also have been tested and used to treat older adults and show efficacy and also safety for the most part. Some notable exceptions are that we're concerned about drugs that are more anticholinergic, causing cognitive impairment in the older patient. We're also concerned about patients that might cause postural hypotension, increasing the risk of falls. The dose of an antidepressant for an older patient should be lower to avoid the side effects, but not so low that the patient's ineffectively treated. And so for that reason, we start low, we go slow, but we don't neglect to treat adequately. Now, one of the complications of untreated depression is that the patient can become suicidal. And suicide in older patients is preceded by depression more commonly than any other psychiatric disorder. In older white men, 85 and above, the rate for suicide completion is 5 times that of the general population. It's even further increased when there's social isolation, physical illness, alcoholism, pain associated with the depression. We want to recognize depression in order to reduce the risk of suicide. And as it turns out, many older adults with depression do visit their primary care physician or nurse and are not diagnosed properly with the depression or treated adequately. This is very unfortunate because now we have model studies showing that we can treat depression in primary care settings pretty adequately in many cases. Some of the studies have shown, and I'm thinking particularly about the Prospect study and the Impact study and the Pearls and Prism studies, that we can co-localize a mental health person in a primary care practice or involve a depression care manager who would be a nurse or other extender of the physician's practice. And this person is skilled in short-term counseling, recognizing side effects, and helping patients pursue and adhere to their depression treatment. These patients who are in these studies have benefited tremendously, and in particular, the substance-abusing older adult or the cognitively impaired older adult or the suicidal older adult may do very well in a situation where they can consolidate their treatment, both for primary care medicine and also for their mental health care. That shouldn't discourage us, however, from using psychotherapy. And in addition to medications, several psychotherapies have been shown to be very effective in treating depression in older adults. In fact, a consensus committee stated the opinion, which I support too, that in the patient with mild depression, psychotherapy is a very adequate alternative to medication. And as the depression becomes more severe, or especially if it's psychotic or involved with cognitive impairment, medication becomes a more important part of that treatment. However, for the milder depressed patient, psychotherapy of CBT or of interpersonal therapy or of problem-solving therapy have been shown to be effective, well-tolerated, and very useful tools for treating depression in the older adult. Thank you for listening.